I am Pedro Avila. I am the Associate Editor for the JACI for papers on sinusitis. And I have with me now Philippe Gevaert. He's a professor at the University of Ghent in Belgium. He has done a lot of clinical trials on chronic rhinosinusitis. More recently, he published last year in the JACI a clinical trial in which he used Omalizumab, anti-IgE, for patients with nasal polyps. Can you talk to us about that study?
Well, it's the first study with Omalizumab anti-IgE treatment in nasal polyps. And what is very important in the study is that we selected carefully a kind of patients, that's nasal polyps with asthma. And what is important in these patients is that nasal polyp patients with asthma tend to have high local IgE levels. We have shown that in previous studies that local IgE in the tissue is there very high. So we aimed to inject the anti-IgE in exactly that group where we know that we have high local IgE levels. What is important in this study is that we didn't select the patients based on skin prick test positivity. So randomly, actually, we were lucky that 50% of the patients were more or less non-atopic based on skin prick test, and 50% were atopic based on the skin prick test. And what we see, not to our surprise, is that actually both groups reacted equally on the anti-IgE treatment. So both had a positive effect of anti-IgE injections.
Okay. So even though the skin tests were negative in many of those patients, your group has found that they developed IgE against the Staphylococcus enterotoxin B, right? SEB. So many of those patients may not have IgE against aeroalbumin, but they have against enterotoxins.
Yes, we believe that Staphylococcus aureus enterotoxins are a main driver. They actually amplify the response, which is locally there in the nose. And what is very characteristic for this amplification by Staphylococcus aureus enterotoxins is that you have a polyclonal IgE, which is directed to many different epitopes.
So that was like a proof of concept phase 2 trials. Are you guys planning any phase 3 trials?
Indeed, this is only the first step, and we hope that we can do in the future new trials. I think they are absolutely necessary, big multi-center trials looking for the best treatment schemes in, and that's very important, in selected patients, nasal polyps with asthma.
Also, 2 years ago, you published another clinical trial in which you tried the anti-IL-5 for patients also with nasal polyps. From your experience, do you have an impression which one was better, anti-IL-5 or Omalizumab, the anti-IgE?
Well, the protocols of both studies were almost equal, so we can compare a little bit what happened. The primary endpoint was similar, also symptom scoring was similar. The only thing which was different was the selection of the patients. In the Omalizumab study, we clearly selected nasal polyps with asthma. In the others, it was nasal polyps with and without asthma. So we cannot compare fully. But to my opinion, the anti-IL-5, we had about 50–55% of the patients reacting to the anti-IL-5 treatment. Whereas in anti-IgE, Omalizumab, we had about 60–75% of the patients reacting to this treatment. Also, and that's also different, although the sample sizes in both studies were equally small, we already had significant improvement of symptoms with anti-IgE and also of quality of life. And actually I didn't expect that I only expected that the primary endpoint, the nasal polyp score, would be significantly better after treatment, but also the symptoms and the quality of life was better, although the small groups of patients. So to my opinion, Omalizumab works a little bit better than the anti-IL-5.
Good. And those are very important phase 2 trials. I look forward to phase 3 trials, and hopefully in the near future can use those medications, and they're going to become FDA approved for patients with nasal polyps and chronic rhinosinusitis. Thank you.
Thank you.